So while not great evidence anecdotally and face validity, it seems to provide a fair amount of benefit. Question 3 now. So that directs the treatment on question number 2. Question number 3, what's going on with this person as a whole to cause the symptoms to persist? So we had 4 categories of issue we were going to address in the cervical spine: dynamic instability, oculomotor dysfunction, nervous system sensitization, and the psychological issues. So as you might suggest, if they have signs, and I need to add the word dynamic instability, not passive ligamentous, you do stabilization training. Oculomotor dysfunction, you do the oculomotor phasic exercises. Nervous system sensitization, education and graded activity, psychological overlay, education, graded activity, and if necessary, psychological intervention. OPTP does sell these stabilization exercise books, which will teach you the protocol. So, first and foremost, and if dynamic instability, they test positive on the dynamic instability test, is to work with them on posture, getting into a good craniocervical seated posture so that the head's balanced above the shoulders above the pelvis. And then to teach them the cervical brace, just like we did the co-contraction maneuver in the lumbar spine, you want to teach them cervical bracing prior to the engagement of all these different exercises that they can become involved in. And remember, it's the long cervical flexors and the extensor muscles in the lower cervical upper thoracic region. So this is the way the maneuver, and it should be done sequentially like this. There's first a protraction of the head and chin forward, then a retraction maneuver. It isn't so much tipping the head down as retracting the chin from that position, and then bringing it back to a more neutral posture. And from that is how you engage the long cervical flexors and lower cervical extensors, is this series of movements. It's been said, it's been described as you had a scoop on your chin and you were going to scoop water out of a bucket. So it's that kind of a scooping movement. And it's described that you should do it in that fluid type of motion. So that, think of a scoop on your chin and you're scooping into a bucket to pull water up and out. And that's the maneuver. And then you just hold from that neutral position with the chin retracted in that posture right there. And that's the beginning co-contraction state that you can now add on additional exercises, like raising the arm out, raising a leg back, and then almost like a cross-crawl patterning, where you're lifting the left arm out and the right leg back. Now, fun-filled fact from South Africa, which I never knew. Quadrupeds, when you watch them walk, it's usually in a cross-crawl patterning. Bipeds, we walk in a cross-crawl patterning. Giraffes do not. Which someone pointed out to me, and then I watched, and they don't. When a giraffe walks, they step forward with their left leg, front and back leg at the same time. Then they step forward with their right front leg and back leg at the same time. Don't know why. And their front leg bends with the elbow, so to speak, forward, and their back leg bends with it backward. Trivia questions. Maybe you'll be on Jeopardy one day and they'll ask that question about animals that are not cross-crawl in their gait. Once you've done the engagement of the long flexors and lower extensors, you're holding that brace position, You can even advance to things like having them balance a book on their head. Again, the key is to get them to hold that brace maneuver before they do all the rest of this stuff. It isn't just balancing a book on your head, it's holding the brace maneuver and then doing the other stuff. And even getting as fancy as adding the movements, bringing in a gym ball, but you'll notice he's doing the cervical brace before he does anything else. And even a gym ball in a book, if you want to go so far. Brugger's exercise is meant to engage. It's common to see shoulder dysfunction, scapular dysfunction associated with some of the cervical complaints that we see. So one of the ways, which I apologize I didn't include in the diagnostic part, to assess for scapular stability, and I'll mention it right now, is to have the patient just take a 2 to 3 pound weight and hold that in front of them while you're looking at their back, and hold it straight out to the side. And then you're looking, and you can even have them lower it and raise it. And what you're looking is for symmetry of movement, that with shoulder movement, you don't engage the scapula until about 30 to 60 degrees, and then you start to get scapular glide. So if you see aberrations in movement or winging, or asymmetry from side to side, then you can start to do an exercise like Brugger's to help engage the scapula to try to add some scapular stability with the movement. With Brugger's, it's sitting at the edge of the chair in a nice upright neutral posture with the head balanced above the pelvis, externally rotating the arms and wrists, and then bringing them back. But this isn't, and this is a specific part of the maneuver. You're not trying to touch your shoulder blades together and back. You're just trying to get maximal external rotation of your arms and extension there without pulling your shoulder blades back together. Just by doing that maneuver, you really engage a lot of the shoulder muscles without overtaxing them or without bringing them into a position where they no longer become active. You kind of get maximum contraction of some of the elements of the trapezius just by doing the full external rotation maneuver and extension at the hands and wrists. And it feels great for anybody who has any kind of protraction of their shoulders. You can also have them do these wall angels, where you put your butt and your head against the wall, you keep your forearms against the wall, and then even see how high up you can slide. You can do it on the ground, or you can do it up against the wall. And you'll find out how restricted your patients are in mobility. Cochrane did do a review of exercises for neck pain, and they did conclude, and they're a tough group to get to agree to anything in terms of being beneficial. They're a very critical and skeptical group, the Cochrane review people. The evidence has to be pretty compelling for them to say that it's beneficial. Stretching and strengthening for cervical problems is beneficial. It's best when combined with manipulative therapy. This would, I would venture to say, be more for the dysfunction people. And probably it's better if it includes oculomotor exercises. These are particularly for patients with whiplash-associated disorders. It needs to include some self-efficacy work, where you're helping to build self-efficacy with your patients, and also active coping versus passive coping mechanisms. Early on, active range of motion seems to help people. So sticking a whiplash patient, save for those who are showing ligamentous instability, in a collar may be detrimental. Getting them moving fairly early on seems to be more beneficial. Getting the patients to do these exercises at home is very beneficial, so that you give them home care. Now, Oculomotor dysfunction, and how are we going to approach it? Remember I told you about Ravel's test? You could send them to a lab where they can actually do fairly complex oculomotor dysfunction testing. It almost doesn't matter. Anybody who comes in with upper cervical problems, particularly traumatically induced, and that's very common in whiplash-associated disorder patients, give them the oculomotor exercises. Don't assess for it. But if it's upper cervical, give them the oculomotor exercises. You don't have to test for it. And here's how you do it. They're phasics, so you would have the patient pick a point in front of them and focus on it with their eyes. You then have them raise their thumb up to the side and they rotate their head and look at the spot out here laterally. Then as they drop their arm, they return their gaze to the point in front. And then you would have them repeat it to the other side. So they focus on the point in front, raise their arm, turn their head, look at the point to the side, lower their arm, refocus on the point in front. And the key is that they focus their gaze at the point in front and then to the point in the side. And you just do these relatively quickly. And you can also do it not just with the turning of the head, but with the turning of the head and the whole torso. So you're just engaging a little bit more of the musculature. Remember, it's a vestibulo-ocular cervical reflex that you're really affecting. Both the VOR, the vestibulo-ocular reflex, and the core, the cervical ocular reflex. So in this case, it's the same idea, except instead of putting the thumb up to the side, you pick a point behind and a point in front. You focus on the point in front, have them rotate their head and their upper body to focus on the point behind, and then return to the point in front, and then repeat to the other side. So it's just engaging a lot more of the musculature. But those are the two phasic exercises. Anybody who comes in with upper cervical trauma, give them these exercises because you can just assume that they most likely are going to have oculomotor dysfunction. And Fitz Ritson was up at Canadian Memorial Chiropractic College, did some work on outcomes associated with doing oculomotor exercises. These were chronic whiplash patients, and they either got standard treatment or that standard treatment plus these phasic exercises I just showed you. And the outcome measure is a decrease in the neck disability index score, which, by the way, I don't know if people know this, was developed at Canadian Memorial Chiropractic College by Vernon and Mior. So Mior and Howard Vernon. And it is the most widely used functional outcome measure for cervical spine in the world. So you can see the standard treatment is the blue. They only had about a 5% decrease in NDI. If you added phasic exercises, look at this, almost 50% reduction, between 40 and 50% reduction in neck disability index score. So that's a really significant improvement by adding those two simple phasic exercises. This is outcome in chronic neck pain patients after doing those phasic exercises on their pain. Now, granted, the exercise group started out with more pain than the non-exercise group. But doing the phasic exercises, there was only a little bit of a drop in the ones who didn't do the phasic exercises, a really substantial drop in those who added the phasic exercises. Another outcome measure in neck pain patients after doing the phasic exercises and looking at rotation repositioning. So what they looked at is your ability to do Ravel's test, the one where they close your eyes and put the laser pointer on your head and see if you could come back to the same position. And after doing phasic exercises, did that improve? And in the exercise group, you can see a really substantial improvement in their ability to do Ravel's versus those who did not do Ravel's test, almost no change in their ability. Those who didn't do the phasic exercises, almost no change in their ability to do Ravel's test. So that's why I say you don't have to measure oculomotor dysfunction. If it's upper cervical trauma, give them the phasic exercises. Now, nervous system sensitization, I don't need to say too much more about this. It's graded exercise, graded activity, and education. It's a lot of contextualization of cognitive behavioral therapy. It's empowering the patient, building their self-efficacy, reducing catastrophization, helping them to understand that hurt does not equal harm. They're not doing tissue damage. The language you use to express all those ideas really influences the patient. And then, work hardening programs are really interesting and probably more driven by the employer's unwillingness to get the patient back to work, when in fact, if you're going to simulate the work you want them to do, if you can do it in a controlled way, why not put them right back into the work you want them to do as best you can? But you'd have to be able to have some control over regulating how it's done. For psychological conditions, again, it's the same kind of a treatment. It's education, contextualizing things like cognitive behavioral therapy, motivational interviewing, acceptance commitment therapy, and then desensitizing them, doing graded activity. Even with your exercises, if they can't do 10 to 15 reps, start them out with 2 reps. But help them build some sense of achievement and self-efficacy here. When a psych intervention is needed, again, we've talked about it in the lumbar spine, it's no different here. It's a judgment call. You have to be the one who makes that decision about when that may be appropriate or not. And we don't have any clear answers. Perhaps if they fail a course of your care and you're strongly suspicious there's a lot of psychosocial issues, that might be the appropriate time to approach a psychologist and ask them to get involved. Certainly a chronic pain patient who has addiction issues, absolutely, you're going to need to get some psych intervention going there. Good. So any questions? So that kind of wraps up the idea of the 3 essential questions from a diagnostic and a treatment. Again, the whole point is where you categorize them from the diagnostic part of the questionnaire then directs what treatment approaches you utilize. And I would venture to say this. You all aren't going to shift the way you're already doing things to adapt to doing it exactly this way. And right now, that's probably not necessary. But you need to bring probably, most likely, more structure to the way you're working up these patients and making sure that you're capturing them in a meaningful way, making sure that you're using language that's empowering, not catastrophizing. And using a standardized approach so that you can be more consistent with the outcomes that you're getting for the patient and more consistent with who's being appropriately referred to different specialties or different services. So the more structure you bring to it, the more you can improve on the model. If the model is just being done haphazardly, then you never really know which variable is the one that's helping or the one that's hurting. The more structure you bring to it, the better you can get. So it's 2. Let's take a 5 to 10 minute break. We'll finish up with vertebral artery stroke and then go into a case study that I think will help a lot in clarifying the way we think about that cervical spine reasoning process. Good. So just a quick 5 minute break. Please stand up and stretch a little bit so you move.
Real quick,